Hey guys, this is Dr. Mahajan from Mahajan Medical Center. Very excited to bring our webcast from our studios at Mahajan Medical Center in Largo, Florida. For those of you who don't know me, I'm a board certified internist, and we do this once a week. We move the timing from Thursday to Wednesday. So, for the folks who are joining us, it's not a intro, which I typically do on Wednesdays. It's a full show today on how to prevent cancer, the big C word. And we're very excited. We got a very bright and amazing talent in our area, Dr. Makani, and she joined a local cancer group, specialist group, and we are very excited to have her in our middle. So I'll introduce her in a minute, but we're going to talk today about the various common cancers we see in United States or Western countries. As you know, anytime we hear word cancer, and that's a scary word, and it should be because depending on what kind of cancer you have and what stage you have, it could be a serious diagnosis, and most of the time it is a serious diagnosis. And the question is, what can we do to prevent it? We should not get to that point, and we'll share some data with you where you will see that even cancer is a preventable condition in 40% plus of the cancers, which is huge. 40% of the cancers, if you can prevent, you will say, wow, what should I do? And that's what we're going to try to address with Dr. Makani's help. All right, so without further ado, let's get Dr. Makani with us. And please give us your love. This is, again, want to bring up, it's not a replacement for any doctor-patient relationship. Any information we share here is just for general education purposes. If you need to see me for any cancer-related conditions, then you should come to the office. Same thing applies to Dr. Makani. If you have any specific questions for her, again, you have to make an appointment with her. We'll put her number up there on the screen. Again, that's not for, it does not, whatever she's sharing does not constitute a doctor-patient relationship with Dr. Makani. So just a disclaimer here. And then please do share and like our webcast. If you enjoy our webcast, please share with your friends and family. That's how I know that we're doing a good job, and we keep putting a lot of work and enthusiasm through my staff and all the various guests. They put a lot of work too. So do give us likes and shares and thumbs up and love. That does help to get the message across to more wider people. Again, let's bring Dr. Makani in the mix, and here we go. Hello, Neha.
Hi, nice to join you this afternoon.
Thank you for coming to our show. I saw your resume, and I said, I wish my kids have that kind of resume. You got a very resume.
Well, thank you.
Yeah, so tell us a little bit more about your education. You grew up in Southern California, I guess?
That's right. I grew up in a small town called Bakersfield. I'm the eldest of 3 children. And then right after high school, I was like, I'm out of here. I'm going East Coast. So I went to Boston University for my undergraduate degree as well as my medical school. And then after that, I went right back to California. I did my internship and residency at UCLA, University of California. And after that, I had a passion for hematology oncology, mostly because my grandfather, who had prostate cancer, his story really impacted me, and I really wanted to be in that field. So I pursued my oncology training and hematology, so that's cancer and blood disorders training at Harvard Medical School at Beth Israel Deaconess Medical Center. And I stayed on there as faculty, and my primary focus of interest at that time was in colon cancer, pancreatic cancer, stomach cancers. We had my son while we were in Boston, and after 9 feet of snow, we're like, we're out of here. And so that's when we moved to Florida. I've been in the St. Pete area now for about a year, almost a year or so, and we've enjoyed living in Florida.
And so you like me, your spouse is a physician too, correct?
That's right. My husband is an orthopedic surgeon in the area.
Okay, great. So welcome to the area. I know you're in Lakeland at Watson Clinic for some time too, right?
That's right. I was there for about almost 3 years or so.
Right. So, Lakeland is just extension of Tampa Bay. So you've been in the area for what, 4 or 5 years now, right?
For almost 5 years, yeah.
Right. So welcome, welcome. All right. So we're going to touch on a big area today. I know it's you need fellowship and residency to cover all the topics in there. So for the since it's going to be 15-20 minutes, so we're going to hit the key points. And I see there is a common thread, going through the literature and what the PowerPoints you brought, Neha, that there's a common thread in all the cancer prevention. We'll hit that, but I'll leave that mystery out there. What's the common thread? And we'll come back to that in the end. But there is a common thread in cancer prevention in any kind of cancer, and we'll hit that in a minute. All right, so let's bring your slides up. Let's share the screen. Let me bring that up. Yeah, there we go. All right, so we got the right screen now. Let me make it a full
Perfect.
screen. All right, so let's start with this slide here. So you had two tables there. Neha, what is a cancer concerns the Americans the most? And the top two, is breast cancer and prostate cancer. Though that's not the most common cause of cancer deaths, the most common cause of cancer death is right up here, the lung cancer. Do you think it's more emotional that the woman, with the breast and men with the prostate, why, they're not bothered by the lung as much?
So I think there's actually two main reasons we see why breast cancer gets so much, awareness. One is because there's a lot of, social media and a lot of education around breast cancer. There's a Breast Cancer Awareness Month, which is October, which is, very much focused towards making sure women are educated about how to get breast cancer screening and what concerns they should be looking for. There's also, breast cancer survivors, which there's quite a lot of them, do a fantastic job lobbying and trying to get funding for research and also educational and awareness projects for the community. Lung cancer, however, as you mentioned, is still the number one killer when it comes to cancer-related deaths. And though it is a concern among people, there is sometimes stigma associated with lung cancer because it can be related to smoking or other, habits. And so therefore, the concern may not be as high as breast cancer per se. But breast cancer, prostate cancer certainly have a larger number of survivors that really spearhead the education and trying to promote cancer awareness for those two cancer sites.
That makes sense, Neha. Thank you for explaining that. So the first cancer we're going to talk about, the breast cancer, and as you can see on the slide, that's pretty profound that in the United States, about 42,000 plus women lose their life to breast cancer, every year. And then 1 in 8 women, have will develop breast cancer in their lifetime. So that's pretty profound statistics there.
Absolutely. And I think part of the reason that, we identify such high rates of breast cancer is because our screening methods have become more sophisticated. And so we have mammograms, not just 2D, but 3D mammograms, ultrasounds, MRIs. Our radiology techniques have improved, so we're able to detect breast cancer even when it's very, very small, which is to its benefit, which is to our patients' benefits. Additionally, women are aware that they should be getting breast cancer screening routinely. So again, more women are diagnosed with breast cancer. But with time, we've also seen that as our technology's improved and we've been able to identify patients who have early stage breast cancer, patients are living much, much longer with breast cancer.
That's a good point. Let's talk about the causes and the risk factors for breast cancer. Let me bring that slide up. Um, and again, on the audience side, I want you to see the common links we talked about before, and you will see that's going to be a repeat pattern in most of these risk factors. So there's family history, there's genetics, there is late childbearing, which is again a curse of, I guess, the Western civilization, that everyone wants to get their career, which is, which is important, but it does come with this issue of increased risk. And then same thing applied to the early menopause and late menopause, which again, a lot of studies behind that could be hormonal in young girls with the kind of foods we're eating, and obesity again is a endocrine disorder, and a lot of people don't understand that obesity does not just look bad, but it also, the adipose tissue is a active hormone producing cell, so that has profound effect on uh, the cancers which respond to the hormones like breast and the ovarian, pancreatic, uh, and esophageal cancers, breast cancer. So any adenocarcinoma, colon cancer too, has direct relationship with obesity. And then some younger women have increased breast density, and that could be a precursor. And the prolonged use of oral contraceptives, which is important to control, your own, how you want to and when you want to get the kids, but then it comes with its price. And then hormone replacement therapy after menopause. Thank God we getting away from that. It used to be 10, 15 years ago, everyone after menopause was getting Pempro. So with the more studies and awareness, that's getting less. And then we mentioned alcohol and tobacco. So you take it over. I think, I'll
Absolutely. So,
quickly.
and and there's three things that are really key from those risk factors, and those things are three of those factors as a patient, as a person, we have control over. The first one being obesity, and as Dr. Mahajan mentioned, the fat cells or the adipose cells in our body actually produce estrogen and progesterone, which are women hormones, and that actually feeds the cancer. And not every breast cancer, but over 90% of breast cancers are driven by hormones itself. So we know that regular exercise, controlling our diets so that we have, lean bodies is very important, because that reduces the amount of extra estrogen and extra progesterone that is being made. Secondarily, the alcohol intake. So we know that a woman who has one drink per night, so whether that be one glass of wine, one can of beer, one shot of hard liquor a night, has a 25 to 30% increased risk of getting breast cancer compared to the average population. And so therefore, really trying to limit our alcohol intake to just special occasions is so important, not making it part of our daily routine. And thirdly, the tobacco use. What I wanted to highlight here is that studies have actually shown that secondhand smoke increases the risk of developing breast cancer even more so than actually being a smoker itself. And so even if you're not a smoker, but loved ones around you are smoking around you, this increases your risk of getting breast cancer. And so it's so important to try to encourage your family and friends and others around you to quit smoking, because it's so harmful to everybody around them as well.
That's a great point. The smoking, obesity, alcohol. So we got three there. It's going to come again and again. And it's important that people understand 40% plus, and we'll have a slide on that, of the cancers are preventable. So you got to start early though, because if you get obese, it's very easy to gain weight. It's very hard to lose it. And same thing with any of the habits, what you mentioned, smoking or alcohol. Once you get into that lifestyle, it's very difficult to get off them. So it's very important not to get in there first place, if you can. And if you do, at least with alcohol, try not bringing it home. Have it with your friends and family on special occasions, especially when you get into 50 plus age group. Not only the body immune system is not as robust, let's say when you're in your 20s and 30s. Uh, Also, the liver is not as robust in getting the alcohol out of your system. So, not only the cancer is higher with higher consumption of alcohol, you have high risk of fatty liver and cirrhosis as well. So, alcohol is a hidden and accepted addiction. We need to talk more. I know smoking, everyone talks all the time, and you did too, as well as, we need to talk about alcohol a little bit more aggressively in the middle-aged people. And interestingly, women, as you know, Neha, have a higher propensity, as you pointed out, as the metab slows down for clearing the detoxing the alcohol, it lingers longer, and they have more breast cancers, they have more pancreatic cancers and esophageal cancers, and a lot of host of other cancers. Anything you want to add to that point?
No, I think that's great.
All right, so let's go to, now we mentioned that what we should not do, but God forbid, if you have suspicion or you have family history, or just in general, what are the recommendation to find it? Let's look at the current guidelines for that. So these are the different, again, the cancer guidelines, folks, are not written in stone, unfortunately. There is not one organization which we follow. Just that the data changes, the studies bring different perspectives every year. So, and there is disagreement in different societies. So we're going to give you a consensus statement on what should be done. So there are, for example, in breast cancer screening guidelines, on the slide we have 5 different organizations asking for different recommendations. Let's ask the expert, Dr. Makani, what she thinks.
So that's the exact point that we were hoping to bring across to the patients, is that every different society, American Cancer Society, American Cancer Radiology Society, everyone has their own guidelines. But the main take home that we as oncologists usually support is that after the age of 40, you should be seeing your primary care doctor regularly for clinical breast exams. Plus, you should be getting annual mammograms. Sometimes patients will say, oh, I was told I don't need to continue with mammograms because I'm 70 or something. The current consensus is that if your life expectancy is greater than 7 to 10 years and you're healthy and fit, then you should be continuing with routine mammograms to detect any suspicious lesions within the breast. Additionally, there's different types of screening modalities, but the one that is currently top of the line and really is able to detect small lesions, even in dense breast tissue, is the 3D mammogram. And so I really wanted to highlight that after the age of 40, annually, and 3D mammogram is really what most oncologists recommend. But by all means, you should be following up with your primary care doctor routinely to make sure that you're getting the appropriate screening. If you have a family history of breast cancer in a first-degree relative, so your mom, sister, daughter, if one of them have breast cancer at an earlier age, you should be starting screening 10 years prior to their diagnosis. So for example, if your mother had breast cancer at the age of 43, then you should be starting mammograms and routine screening at age 33, 10 years from the time your mother was diagnosed. So those are really some key take-home points that I wanted to mention about breast cancer screening.
That's great points. Let's see if the screening saves lives. So can you walk through the graph? What we see here?
Absolutely. So patients say, well, once I get cancer, that's a death sentence. And so, like, what's the point of getting mammograms and finding out that I have cancer early? So, what this slide is highlighting is that if you are found to have stage 1 breast cancer, meaning a small tumor that can be cut out, the chances that you will be alive at 5 years is almost close to 99 to 100%, versus patients who delay or don't get the appropriate screening or testing, who present with later stages of disease. So the cancer has already spread to other parts of the body, their liver, their lungs, their brain. That is a stage 4 diagnosis, which is the last stage of cancer. And unfortunately, those patients do not live as long. And so that graph is really highlighting that early detection, finding those cancer cells early when they are small, helps people live longer and almost live a normal life expectancy. Additionally, with mammograms, we can even detect stage 0 breast cancer, meaning there are cancer cells that are there, we can detect them, they still haven't yet formed and invaded through any invasive structure, so we can even detect it at a stage 0, and those patients essentially live a normal life. But the key is early detection through mammograms, ultrasounds, MRIs.
All right, so you mentioned other modalities now. So let's talk about, what is the role of MRIs and diagnostic mammogram and ultrasound? Is it more as if you do find something on a screening mammogram, as you mentioned, 3D is the way to go, then you go to them, or if you have someone special cases where you like a dense breast or something like that, then you give different recommendation.
So great question. So when it comes to the MRI of the breast, in younger women who have, more dense or breast tissue, we often recommend, if you have a family history, that you alternate MRI with mammogram every other year, because the MRI is able to detect tumors in different density, in different breast dense tissues. But in terms of ultrasounds or diagnostic mammograms, that's usually recommended after someone has had an abnormal screening mammogram. So basically, the main modality is still just a 3D mammogram for most women over the ages of 40. But for younger women or women who have very dense breast tissue, which usually the radiologist will comment on, at that point, MRIs can also be used intermittently as a means to screen for any breast cancers.
What is the role? Let's ask a controversial question to Dr. Makani. What is the role of the genetic testing, if any, in a cancer detection, or more knowledge? It causes anxiety, whether how much for sure they're going to get it. And then if they find out, are they ready for mastectomy? So, what's the role of genetic testing in breast cancer?
So that's a very important question. And so the way we approach it, we as an oncologist usually approach it, is if you have been diagnosed with breast cancer under the age of 50, we do recommend getting genetic testing to see if there is some genetic predisposition as to why this cancer may have occurred. If you do not have a diagnosis of breast cancer, but you have, one first-degree relative, meaning mom, sister, or daughter who had breast cancer under the age of 50, then we also recommend trying to get genetic testing. And there's many products or many different lab tests that can be ordered looking at various multitudes of genetic mutations. Commonly, we think of BRCA1 and BRCA2, but there's actually a whole panel of tests that can be done. Once you get that result, it's important to follow up with your primary care doctor or seek out a specialist to really find out, what does this actually mean if something is abnormal? What are my odds of getting breast cancer? Is it really higher than the average population or not? And if it is, then there's a multitude of options available to you, whether that be surgical removal of the breast, like a mastectomy. That's what, Angelina Jolie, famous actress, did when she found out she carried the genetic predisposition. But there's also medications people can take to try to reduce the odds of their cancer, of developing breast cancer. But the way I would approach it is, to not be afraid of the results. Sometimes knowledge and knowing and having that power gives you more options versus being afraid of even approaching that subject.
I think great point. I think into the mix whenever you do a genetic testing is the role of genetic counselors come in too. They have a lot of knowledge of the research, and they have a lot of time and patience, and they do it every day. So, in getting their services also helps the families and the person in particular whose tests unfortunately come back positive, what they are looking at with the current data. So I think in addition to primary care and oncologists like you, I think genetic counseling is very useful in my experience.
Absolutely, and the nice thing is when we order these tests, most every lab that we order from genetic testing does include a genetic counselor. Even if it's through a phone, you may not actually have to go to them, but that genetic counselor can be invaluable.
So it looks like you're doing a great job. We got a comment from Kathy Hyde. She's a registered nurse, and she does a lot of, she goes to all parts of the world. Now she's just retired, and she does hazard nursing. So she goes to wherever there are earthquakes, and she's done a beautiful job over the years. So she likes your presentations. You must be doing good. She has high standards.
Thank you, Kathy.
Thanks for watching. Let's just get some comments in there. We got Deborah Hawking saying, I love this lot of good information. Thank you, Debbie. We got Anu Durai watching. Thank you, Anu. We got Tillman's watching. Thank you, Loretta. And Mr. Tillman, Mr. and Mrs. Davis are watching our show. Thank you so much for supporting our webcast. John has a unrelated question. John, I touched on it my last podcast. I'll also do it again. I know this is a topic in everyone's mind, but we'll do it in the end. Today we're talking about cancer, but if you want to, you can go to YouTube or Facebook and look at the previous podcast. I did a whole segment on vaccines, but I'll briefly touch it before we do the breathing exercises. I know that's an important topic. All right, so let's go into, we gave the woman the first right. Now let's get men's concern about the prostate cancer. So why it's important. So the prostate cancer, as you can see, the new cases are going up. They're not going down. From 2019, there are 20,000 more cases in 2020, and we're not even done with 2020. And then look at the death, same way as the incidence goes up, the death goes up. We got 33,000 deaths plus this year. And every man will be diagnosed every 2.7 minutes, and a man will die from, every 16 minutes. So that's pretty profound as breast cancer as well. Let's get Dr. Makani's take on the data here.
So yeah, this was just highlighting really the incidence of prostate cancer. A lot of men are told, appropriately so, that you have prostate cancer. It's very low risk. You probably will live with this and die with this, but not die from this. However, not every person who is diagnosed with prostate cancer will have that reality. So there are certainly cases of prostate cancer that can be quite aggressive, that do need to seek attention from urology, medical oncology, radiation oncology, and those facts and figures are just highlighting the importance that there is a certain population of patients with prostate cancer that really struggle with the disease.
So let's bring that population and the risk factors up here, Neha. So, we see age about 50, ethnicity, men with Afro-American, Afro-Caribbean descent. They have more risk of prostate cancer. Not only they have more risk, they have more aggressive prostate cancer as well. And then the family history, again, similar to breast cancer, if you have first degree relative, and then again, the common link we kept talking about in the breast cancer, the obesity is a link. So anything you want to bring up among these things, Neha?
So I think all of those are pretty much the main risk factors. Things to remember, especially with that first degree relative. So if your dad, son, brother has been diagnosed with prostate cancer, that's something to certainly bring up to your primary care doctor so that you can get the appropriate screening for prostate cancer.
Now you're talking about screening. That brings us to the next segue. And that's a very controversial topic about screening and prostate cancer. I wish we settle on it, but it's been decades and decades of back and forth. So I put the slide up there, and I won't go through the details because, again, this is still not settled issue. So, what's the consensus? What's a take? A expert like you will say, what should be used for screening, and what should we do, and what age?
So usually we recommend that, over the age of 50, men are certainly getting prostate cancer screening. And if you have a first degree relative, starting at a younger age, even starting at age 40, we recommend, some type of screening for prostate cancer. There is the actual prostate exam that can be done to look for any enlargement or nodules of the prostate. But most patients are getting a blood test done, which is a PSA. And you would think, oh yeah, I get blood tests done all the time, so what's the big deal? I get a PSA level checked. But once you get that PSA level checked and you get given a number, what happens after that can sometimes be a whirlwind of options. And so we know that every male has some PSA that's in the bloodstream. And there's many things that can affect the PSA. If you have a urinary tract infection, if you have any kind of irritated prostate, if you've recently had any sexual activity within 24 to 48 hours prior to the test, all of these factors can affect your PSA level. And so when we get that PSA number, we don't want to have a knee-jerk reaction of, oh, it's a little bit elevated, need to rush and get a biopsy done necessarily. But things that we really look at is the trajectory. So if your PSA seems to be abnormal today, maybe we want to repeat it in 3 or 6 months. And if we see, gosh, there really is a steady incline of that PSA level, that makes us certainly more concerned, and that a further evaluation with a urologist would be recommended at that point.
So that's a great point. And the thing with the prostate exam, breast exam, these are intimate exams, and that's difficult for patients because, especially men, you know, women have it too with the mammogram and breast exam and pelvic exam, but men are, and especially some ethnicity, it's not very easy for them to come to the office. Mostly, I've seen women drag them to the office to get it done, and I think you make a good point. If 50 plus men, and especially if they belong to the ethnicity we highlighted, the Afro-American, Afro-Caribbean, or if they have family history, first degree relative, it's very important to, despite the controversy, don't let the controversy, give you a piece of false confidence. They don't have it settled yet, which is true. We don't have it settled yet, but still, in those patients, we know for sure they'll be higher risk, right?
Absolutely.
Okay. All right. So let's see if the screening works. So walk us through this slide.
So again, this is a common theme that, screening saves lives. So if we can detect that prostate cancer at an earlier stage, stage 1, and sometimes the treatment is just observation, nothing is really even done. Sometimes the treatment is surgical, or sometimes it's radiation, or sometimes it's just, injections that you get periodically to lower that testosterone level, which often feeds the prostate cancer. So there's a whole wide array of treatment options. But we know that if you're found to have prostate cancer and it's very small, stage 1, you can have almost a normal life expectancy, versus unfortunately waiting till stage 4, then it is a terminal condition, and unfortunately the survival is not as good. So screening, detecting that cancer early certainly helps improve survival, which is key.
Yes, that's a great point, Neha. And the other point is getting once a year on your birthday or whatever, and fixing with that schedule is good, because then we can do, most of the screening. Will come to the colorectal cancer screening in a minute. So that's more, for example, from primary care perspective, and it's good to for the patients to write it down too. It's our job to make sure when you come that we should do all of that. But it's also, if the patient has a checklist, and and they know what's their high risk or which age they are at, come once a year and get all that done in one shot. So then it become automatic. And otherwise, everyone has kids and jobs and stresses, and you keep postponing. So it's important to just do everything in one shot, whether it's colorectal cancer screen with a stool card, or breast exam with the physician, or or mammogram, or prostate cancer screen with a PSA with a blood test. And you can combine the other blood tests like your lipids and your sugars or your kidneys or your liver, whatever you do once a year, with the PSA if you're in a higher risk and you're 50 plus male. So make it more automated. That's what I'm trying to say here.
And the other thing just to highlight is that, when you're a new patient, we have these new patient intake forms. We ask in great detail your family history. And then after that, time can go by and you have family members that are being diagnosed with different diseases or cancers. Please make sure you let your doctors know that, oh, since I last saw you, my sister or my brother or my dad was diagnosed with this. So that way we can keep an updated chart of what's going on with the family history, and also give better guidance of what screening needs to be done, how often needs to be done, and what is the best test for you.
Yeah, great point. Let's dive into colorectal cancer again. Not as sexy as breast, but still number two leading cause of cancer death combined in men and women in United States. What's your take?
And so, this is really colorectal cancer is really a cancer mostly seen in westernized countries. And we're going to talk about the risk factors in a moment. But what I really want to highlight, especially in this section, is that this is not just preventable, but actually treatable, actually through the screening modalities that are available. So colon cancer, it's the second leading cause of death in cancer-related deaths in the United States. But this is something that is definitely preventable and even treatable if caught early with the treatment options that are available.
Yeah, that's a great point you bring, Neha, that this is a cancer where the screening modality can cure it too. So, we don't have any other cancer that way, that you go in and maybe bladder cancer, but again, that's a difficult cancer to diagnose. But colon cancer, it's just a prep, which is the hard part. But let's look at the risk factor. All right, so risk factors of colon cancer. Again, this is again the curse of Western civilization. Lifestyle cancer, if you want to. And again, the common theme, what I was alluding to when I started this segment of cancer. If you zero down, again, you will think, gee, man, this is the same slide we're seeing in all the cancers. And that's true. If you look at the risk factors, obesity, especially in men, smoking, you would think, gee, man, if I smoke, I can understand it causes lung cancer. How about colorectal cancer? People don't realize that smoking, there's so many chemicals in the smoke which get directly absorbed by the lungs, and it's like you're feeding your intravenously. It goes directly to your bloodstream, and it goes through all the organs, as distant as colon, as distant as pancreas, as distant as bladder. Bladder cancer is hugely related to smoking, and you would think, gee, it should be only lung, but lung is the direct irritation. All the other organs get the rest of the chemicals supplied on regular basis, unfortunately. So obesity, again, same concept we talked earlier. Racial and ethnic background, again, Afro-Americans have highest colorectal cancer rates. And part of it is education too, and maybe it's our medical system fault, and we'll talk about that in a minute, that the access to care could be a big player here with the minority community. So more education, like program like ours, telling people, hey, the Afro-American community has more risk. They should seek out the standard of care, which is not very difficult, once we come to that in a minute. Type 2 diabetes, which is interesting, but again, lifestyle disease. If you look at it, obesity, type 2 diabetes, physical activity or lack of physical activity, and age 50 plus. And then again, alcohol comes into play. We don't talk as a society much about alcohol. We talk more about cigarettes, but alcohol again comes into play in this. And red meat and processed meat like bacon. What stands out to you, Neha, on these?
So what's really important is the World Health Organization actually classifies red meats and processed meats. So that's your salamis, pastrami's, bacon, prosciutto, all of those as actually carcinogenic. And we know that animal protein, especially coming from red meat, directly causes more inflammation in the lining of the intestines, in the lining of the bowels, which directly causes these cancer cells to start growing and dividing. And so these are habits to instill at a younger age. So trying to make big lifestyle adjustments later on in life is not only harder to do, but sometimes the damage has already been done. So trying to instill these good, healthy habits, getting mostly vegetable proteins, trying to make sure you have fresh fruits, fresh vegetables, diet, healthy diet. Those are habits to start instilling at a younger age in your children and grandchildren, so that we can prevent this type of cancer, because we see that this is very much mediated by diet, alcohol, smoking as the top 3 risk factors really for colon cancer development.
On the same topic, I want to add that if you use more fiber in your diet, plant-based diet, things with skin like apple with skin or cucumber with skin, if you think about it, the fiber is a gold element we don't talk as much. It's like a broom, if you may, because it's not broken down by human gut as much. So it comes down to our colon. And if you have a very small polyp, which is just in a budding stage, and your stool is nice and bulky with all the edges of the fiber, think of it's like it's you scrubbing the literally the cancer off your the colon. So I think we need to talk more about fiber and more fiber in the diet as long as you can tolerate. Some people can't, but if you can tolerate more fiber, that will help you a get more satiety. B, it's a prebiotic, so that means it provides the network or the skeleton, if you may, for the friendly bacteria or microbiome to thrive in your gut. And we are just scratching the surface of the relationship of microbiome and the immunity and relationship with different diseases, including cancers. And I think the weight is huge with microbiome. If you have a healthy microbiome, your weight is better controlled. So, and that again ties with the cancer. So that's the link I was talking earlier. And I think fiber and the plant-based protein and plant-based diet has a huge advantage. And that's why we see colorectal cancer much less in developing countries, right?
That's exactly right.
Okay, let's talk about how can we screen these cancers. Oh, here we go. So, you come to my office and, we say, okay, you turn 50 plus, welcome to the Middle Ages, and, here is a colonoscopy referral. And, it's difficult because you think, you don't want, it's not for you. But the data is pointing again and again that there is no substitute for colonoscopy. So, and as Dr. Makani pointed out, the beautiful thing about colonoscopy, if there's a beautiful thing about colonoscopy, is that while you see it, you remove it. And if they are even precancerous, and hopefully the gastroenterologist did a thorough job in looking for all the polyps out there, you're good. For at least 3 to 5 years, depending on what kind of polyps they found. And then in between, or as an alternative, let's say you have a lot of surgeries and you can't do colonoscopy, or if you have adhesions and it's very painful and they tried and they couldn't pass it through, you have strictures, then the next option is the fit kit or looking for microscopic blood, the Cologuard, which is a combination which look for any genetic markers for the polyps as well as blood. So it has a dual purpose. And then the fancy one, the virtual colonoscopy, which has not caught up as much, because of the, it's just that the radiologists don't have as much experience, but it's catching up in patients who can't do real colonoscopy. But the problem with the virtual colonoscopy is, once you find a polyp, then you have to go to real colonoscopy. So why not go to real colonoscopy? Anything else you want to add here?
So just very briefly, there's two tests that can be done that are not procedures. The FIT test, which is really not ideal. It's really just looking for blood in the stool, and oftentimes we can miss cancers. So it's not the best test. The Cologuard test does require you to submit a larger stool sample, so that it can be looking for different DNA abnormalities in the stool and shedded cells to look for cancer. But if you have a family history of colon cancer, the Cologuard test is not a good test for you. If you have anemia or if you have low red blood cells, the Cologuard test is not a good test for you. If a Cologuard test is positive, meaning we're worried that there's something concerning, the next step is a colonoscopy. In terms of the three tests that are available that are procedures, flexible sigmoidoscopy can be done in the office. It doesn't require a full bowel prep, but it's only really looking at half of your colon. And so it's not really getting a full idea of what's going on with your colon. And so it's really not the best test to be looking for colon cancer. The virtual colonoscopy, as Dr. Mahajan mentioned, is not that popular for two reasons. One, you still have to do the bowel prep to do the virtual colonoscopy. And secondarily, if there's even any abnormality, the next step is, boom, do another bowel prep, and let's go in and do that colonoscopy. So the third test, really still the gold standard, is a full colonoscopy. Bowel prep is needed. Bowel preps have changed with time. Patients are not having to drink gallons and gallons of Go Lightly anymore. There's other means to really clean out the bowels. But the biggest advantage of having a colonoscopy is that if we find a precancerous polyp and it can be removed, that's it, we're done. There's no further surgeries or other testing or any procedures that need to be done. So the colon cancer screening modality with a colonoscopy not only detects cancers, but also can cure you of early stages of colon cancer. And so, after the age of 50, we really, really recommend getting those colonoscopies every 10 years or sooner if your GI doctor recommends so. And again, if you have a first-degree relative with colon cancer, start your screening 10 years prior to when they were actually diagnosed.
That's a great point. I think that's a standard recommendation, again, a common thread with if you have first degree relative with the prostate as well as breast as well as colorectal cancer, that you got to be more aggressive than the general population.
Absolutely.
All right. So let's talk about does the screening work? So the 5-year survival rate for colorectal cancer by stage, again, is fantastic if you catch it early, 90% plus. And then if you have METs, again, if you look at 12.5%, that's pretty remarkable how far we come with the treatment of the metastatic colorectal cancers, Neha.
Exactly. And there's been certainly advancements in colon cancer treatment, even in late stages where it's spread to the liver or the lungs. But if we can catch these cancers early, there's nothing that can really, beat that. And as you can see with that chart, over 90% of patients are alive at 5 years if they are found to have stage 1, colon cancer.
So the moral of the story is that, get the colonoscopy, what I call light, camera, and smile. Let's talk about the biggie, the lung cancer, the big kahuna in the room. The leading cause of the cancer death in the United States, and it's both in males and females. It's a huge challenge to get this under control. And now, there's a picture of this guy's vaping, and people think vaping is, okay. I just stepped down from smoking, and that increases the cancer risk too. Anything you inhale, other than the oxygen in the air, increases your cancer risk. It goes to your bloodstream directly. What you want to take home from this busy picture, Neha?
So the couple take homes, really is smoking anything, Juul pods, vaping, e-cigarettes, medical marijuana, or marijuana in general, smoking anything damages that lining of the breathing tube, damages the lining of the lungs, damages the lung tissue itself, and can promote and cause lung cancer. Secondarily, secondhand smoke also can certainly increase your risk of lung cancer. 60 to 65% of patients who are diagnosed with lung cancer either quit smoking more than 10 years ago or have never smoked themselves, but were just around secondhand smoke. Of that 60 to 65%, 10 to 15% of patients say, I've never even been around secondhand smoke. So, we don't know all the causes of lung cancer. There's more than just smoking or direct, environmental toxins. But, it's still, unfortunately, such a huge, cause of death and cancer-related mortality.
That's a great point. And, what are the risk factors? Let's dive into that. So number one is, again, as you mentioned, smoking. And if you guys look at how high the risk of the cancer is, just mind blowing, and still people smoke 20 times. I had a lady today, she was 52, and I said, hey, quit smoking. She said, I'm not quitting smoking, it's my choice. And absolutely, it's your choice. But when we find a spot on your lung, then unfortunately, it's too late, and so it's good to, even you quit later in life, it's improve your quality of life. Number one, your COPD and all that, sense of smell, sense of taste. Plus, you'll have more money in your pocket. Those things are expensive by the time you pay taxes and all that, unless you go to Mexico and roll your own. All right, let's talk about the next risk factor, the radon. We don't think of it. It's a silent killer if you live in basements or areas which are high in radon. And you can get a radon detector from Amazon or Home Depot if you want to check what's the radon activity in your area. And if you see a cluster of cases, your neighbors or your friends in your neighborhood have higher risk of cancers, it may be worthwhile checking that. Asbestos, thank God, we have less in Western countries now with the regulations, but the older generations who got pipe fitters and shipyard workers, they still have higher risk of lung cancer and the pleural lining mesotheliomas. And if they do smoking and asbestos, and there are a lot of those folks who've done that, and their risk is tremendously high. So they should definitely look into getting the screening, and we'll look into that in a minute. And then Neha talked about secondhand tobacco exposure, equally bad. If your spouse smokes, you smoke half of it. So if you write down you don't smoke, but your spouse smokes, you should write down I smoke half. Then we know that you have higher risk. Genetics, again, that's always a player in most of the cancers. Other lung diseases, not as common, but a factor. Prior radiation, very important. If you have breast cancer and you had a radiation to your chest, or any other, cancer of the chest like lymphomas or any other cancer, where you needed radiation, or even chemoradiation together, that can increase your risk of other cancers, including lung cancers. Any take home I didn't talk about?
No, I think you highlighted all the risk factors. Fantastic.
All right, so let's talk about what can we do to screen it. So we know that what are the risk factors, so the screening. So this is a very good slide. It gives you the summary, what's the new recommendation for the 30 pack here. So let's see what 30 pack here means. So you may have smoked for 15 years, but you're a heavy smoker, you smoke 2 packs, so that makes you 30 pack. So that's a point to drive home, that you don't need to smoke 30 years. You can smoke for 10 years, but you smoke 3 packs, that make it 30 pack. So anyone 30 pack, or you quit in the last 15 years, but you smoke 30 pack, you should, and your age is 55 to 77, then you should get the low dose CAT scan. And I'll have you highlight the advantages of low dose CAT scan. Neha, go ahead.
Absolutely. So, we often see patients who are diagnosed with lung cancer that will say, well, I had a chest x-ray just like, 2-3 months ago, they never found anything. So remember, a chest x-ray is just a quick, dirty look, but this low dose CT really allows greater detail of looking at the lung tissue, looking at your breathing tubes, so we can really get a good idea of really what's happening in the lungs. But this is a low dose CT. I understand that a lot of patients are concerned about getting imaging testing done because CT scans is exposing your body to some radiation. But a low dose CT has 90% less exposure to radiation than a normal CAT scan. So that's the other thing to really highlight. Thirdly, some patients don't like to lie on that CT scan table, but this is a test that takes less than 10 minutes, and you're just holding your breath just once, and so it's not like a very cumbersome or long test. And then lastly, we know that we can really identify lesions that are very, very small. And so, there's so many benefits of trying to get your low-dose CT scanner so we can try to detect these lung cancers at a much earlier stage.
Yes, and again, we want to talk about, there are different kinds of lung cancer, the small cell, the non-small cell, those are the two biggies. There are others too, but, those are the common ones. And the 5-year survival rate is not very good with stage 4, and not as good as colorectal cancers. So, definitely prevention is better than cure here. What's your take on this?
Absolutely. So lung cancer, a lot of lung cancer can be prevented with just lifestyle modifications and changes. But even if you were to be diagnosed with lung cancer, the big take home here is if we catch it earlier, if we catch it on a low dose CT scan where it's really small, we can cut it out or radiate it or do something to control it, where you can have a very good overall survival. But unfortunately, once it's spread, we are very limited in what treatment options we have. Granted, there have been a lot of advancements in lung cancer. We have better targeted treatments, we have immunotherapy, chemo pills, chemotherapy options, but unfortunately, it's still a very tough disease to beat.
All right, so we covered a gamut of cancer in a short time. So let's give a recap. So we talked about breast cancer. What are the top 3 things you want to take home for breast cancer?
So, top 3 things for breast cancer is being up to date on your screening for breast cancer, knowing your family history so that you're able to get the appropriate screening test for it. And thirdly, being very vigilant about the lifestyle decisions you make when it comes to breast cancer with routine exercise, cutting alcohol, avoiding smoking. So those are really key take homes for breast cancer. Prevention and detection.
Which we covered the prostate cancer. What are the top 3 things you will say take home?
So prostate cancer, again, common themes here, knowing your family history, and if you have risk factors, African American descent, family history of prostate cancer, being open to the idea of getting that PSA test done and then kind of following the guidelines and recommendations after that. And also not being so, patients get very nervous once they get one slightly abnormal PSA. Remember, there's many things that your doctor looks at before we jump to getting a biopsy done.
Great point. And then we talked about the colorectal cancer. What are the top 3 take-home messages?
So top 3 take-home for colon cancer, colorectal cancer is diet. So trying to maintain a very healthy diet that is rich in vegetables, rich in fiber, rich in fresh fruits, and trying to really limit those processed meats and red meats. The second take home really is not being nervous or afraid to get that colonoscopy. Definitely when you hit 50, but earlier than that if you have a strong family history. And thirdly, remembering that that colonoscopy could potentially cure you if you get that test done and you're found to have a precancerous polyp.
And lastly, we just talked about lung cancer. I know they should be fresh in their memory, but let's give them 3 take-homes.
Absolutely. So if you're smoking, quit, not just for yourself, but also for your loved ones. Secondhand smoking also kills, which is really important. Secondarily, that low-dose CT scan, patients are always nervous about, that radiation exposure. Remember, it's not very much radiation exposure. It's a short, quick test, and it can really get a much better picture than a chest x-ray. And thirdly, catching lung cancer early really improves your survival, especially when we hit stage 3 and stage 4 lung cancers. Unfortunately, patients don't do very well.
All right, so let's bring this slide up, which I think sums up what we're just saying about the common thread, which how we started. If you look at this slide, I think it's the most important slide of all the slides. To take home messages that the American Cancer Society is saying more than 40% cancers are preventable. So let me repeat that. More than 40% cancers are preventable. So yes, you have genetic predisposition. Yes, you all that, but you got to make those oncogene manifest itself in the cancer. So if you control what you can control environmentally, you may or may not make those oncogene flare up to produce a meaningful cancer. So, and your immune system, if it's good, you do regular exercise, have a good diet, and don't do smoking, and keep your BMI less 25, if or around that, or consume less alcohol, you can, in fact, reduce your risk. Again, that you can't make it zero. Otherwise, you can control everything with lifestyle. Unfortunately, we can't. But 40% is huge, in terms of being preventable. What's your take on that, Neha?
That's exactly right. Really, you have the power and the ability to control and try to reduce the chances of developing all of these cancers. And making those lifestyle changes later on in life is still worth it. Some patients say, well, I've been doing this for years now. What's the point? It's still worth it to try to quit smoking, changing your diet, starting an exercise routine, and really, really trying to instill these healthy habits at a younger age is so critical. But the most important thing is patients feel like, oh, I have cancer and there's really nothing I can do about it. The truth is, there's a lot you can do about it, regardless of genetics, family history, and other risk factors. And so the power is in your hands.
That's a great point. Power is in your hand. So, is there anything exciting, like Star Trek kind, that you just use a scanner and you say, "Oh shit, 10 years from now, you're gonna have breast, colon, and prostate cancer." Or you can't have breast and prostate in same person. So you can,
So
you'll get breast cancer too, but not as common.
not as common, that's right. And
Anything
so,
you want to talk about?
absolutely. So, when we see our cancer patients, patients are always alarmed that, oh, well, I just had a physical with my primary and they never found anything. And so this really highlights that last month, there's a pilot program being done at the United Kingdom in the NHS system, looking at basically a blood test that can help detect a multitude of different cancers. Now it's in very, very early phases, but if this bears out to be fruitful, it could be tremendous if we can just get a sample of blood and be able to identify if there are any circulating cancer cells in the body. We can try to detect these cancers at an even earlier or precancerous stage. So that's exciting news that's coming up the pipeline. By just being able to detect cancers through a blood test. But I do want patients to realize that right now there is no such test where we do a blood test and we can detect cancer. So I know patients are always alarmed that, oh wow, we've made so many advancements, but how come we can't detect it? We're not that advanced yet.
I think I want to bring another point. Anytime you do a good research in any field, it has beautiful complementary effects in other fields. So let's take example of COVID-19, and people talk about the vaccine. If you look at the mRNA, the mRNA research is all oncology research, which has been reused into the virology now. So, it's a beautiful thing that you do good work in one field, and it comes out handy in other fields. For example, the monoclonal antibodies. It's a largely it has research from the oncology, hematology, oncology background, and now the Regeneron and the Lilly is using that same technology or similar technology for COVID-19 treatment. So any good research, any place has beautiful effect in other fields.
Absolutely.
Yeah. All right. So we're going to wrap up, and I'll give you the podium for your wisdom. Anything we didn't cover you want to bring up other than the lifestyle changes we hopped on, or you want to add anything
Um,
else there?
No, I think the lifestyle changes, and I think, as Dr. Mahajan said, really trying to also take some ownership about, making sure that you're getting your annual screening test, or it's been 5 years or 10 years since my last colonoscopy. Kind of making sure you follow regularly with your doctor so that there's no lapses. So that's really important, and kind of having a calendar, or setting reminders on your iPhone or smartphone, so that way, we're all working as a team so that we can provide the best care to you.
I think more we make it automated, more it's painless. Just keep it on your calendar. Minute you get out of the primary care office for this year's appointment, let's say it's your birthday month or whatever, make it for next year. So then you're not thinking. Then the we will remind you, hey, it's your appointment, and you say, okay, it's time to get it done again. So that's the key. Make it automated. Let's go back to this question. I know it's more for me, not for you, but I'll just talk in general. So the two vaccine, the Moderna and the the Pfizer one, which is going to be similar messenger RNA vaccine. The Pfizer is going to be out. I think FDA is approving today. I didn't check my feed, but I think it's going to be approved because the data is looking good. And the Moderna are going to be piggyback because it's very similar in terms of study structure, in terms of the product structure. The Oxford is a bit different, so we have to look at the data a little bit more in detail. But between those two vaccines, the Pfizer and Moderna, I think if I get a chance, and I'd said that in my previous podcast, I'll take the jab. The reason for that is we got nothing else. Even the remdesivir and the Regeneron and Lilly antibodies, what we have right now, they're not giving a whole lot of mortality benefit. And the herd immunity model has failed in Scandinavia. So the ICUs, if you look at ICU occupancy right now throughout Midwest and Northeast, it's scary. In California, it's scary. So you can't rely on the herd immunity model. So you got to get the herd immunity in a hurry. And yes, there are going to be risk involved. Yes, there are going to be side effects, which we don't know till we given a broader population. But 90% efficacy, if it pans out to be even 80%, it's huge. If you think about it, flu vaccine, which is very similar bug, though it's not coronavirus, but very similar because it's going to be transient immunity, what it's looking like. It's 50%. And we still take it. We still take it. And when you go to any fast food restaurant, do you know what's in your meat? But you eat it. So to answer that question, once offered, please take it because we got nothing else, and we got to move on in life. And the cancers don't stop, the heart attacks don't stop, and if your ICUs are 90% full, guys, that's a scary thought. Where are you going to put the stroke patient? Where are you going to put the patient with meds to the brain? Where are you going to all that mortality with all these diseases? We could easily, for example, a STEMI patient or acute stroke patient, if your hospital chains are burdened, the emergency departments and all those systems are overburdened, the fatigue of the ICU nurses, you see in their eyes, day in day out, they're putting the PPP and and breathing through that N95. Patients have hard time doing the surgical mask for 15, 20 minutes. Imagine their plight that they're doing it for 12 hours, and they're doing day in day out. We need to give a light end of the tunnel, and the only light end of the tunnel is the vaccines. And we have to pay a price in terms of side effects. The side effects so far, the data is showing it's primarily safe. And what's the alternative? Staying on this shutdowns and opening up the schools. I look at my kids, and I know your kids are younger, Neha, but I look at my kids. The education is not the same sitting at home looking at the computers. So as a society, yes, you go out, take your car, you take a risk. Someone, God forbid, can hit you. Same thing, not as much with vaccines. So you got to take a leap of faith and take the vaccine when it's available. No ifs and buts about that. you have anything different to say?
No, I think we're right on the same page there. Believe in science, and we really don't have any other good options. And so then there's always side effects for every medication you take, whether it be Tylenol or an antibiotic. Likewise, this vaccine will have some side effects, but the illness is very serious and very severe, and we're seeing that reality right now.
Yes. All right, let's do the breathing exercises. Are you up for some breathing exercise, Neha, with me?
Sounds good. Let's do it.
So we'll do what's one of my favorite. It calms you down. It's called alternate nostril breathing. In yoga circle, it's called Nadi Shodhana. Have you done it before?
Yes, I have.
Okay, so you're a pro, then you can lead. All right, so a lot of my folks do it with me, so we'll do it. So first, I want you to bring the awareness to your breathing, and we'll take some deep breaths through our belly. If you want to skip that, it's up to you, Neha. I know,
No, no, good.
but with the folks, just get the awareness that the breathing is not just the intercostal muscles. That's the shallow part of the breathing. The breathing is also your diaphragm, which is a big muscle, and your abdominal muscle. And I give example of COVID-19 that I go to ICUs and I see the nurses turning the patient on their belly. And the reason is, we are trying to recruit the bigger muscles by turning them or proning them. Same concept for our day-to-day life. We hardly use the capacity what the good Lord has given us in terms of using the big muscles, which is not the intercostal muscle, which we do automatically, but the diaphragmatic muscles and the abdominal muscles. So let's just spend few seconds on just putting your hands, if you're sitting up, just putting your hands on your knees. And if you want to close your eyes, you can close your eyes and just breathe gently through your nose, breathe in and out, slow in, slow out, focus on your breathing. Just in a quiet place, think of good air going in and the COVID getting out. Breathe in and breathe out. And the COVID-19 has brought, I think, awareness to the breathing as a great tool. It's not only a great tool in patients who have COPD, heart failure, or interstitial lung disease that you can recruit your dead spaces, but also for the emotional aspect, for the anxiety aspect, what we all suffering from this ailment. Are we next? Is my loved one next? Or if they already have it, are they going to end up in ICU? So the breathing is a great tool to control your autonomic, not control, but modulate your autonomic nervous system and helps you calm down. So let's focus on our abdominal breathing. When you breathe in this time, close your eyes and make your belly go forward. And then when you breathe out in exhalation, make your belly go back. Gently, you don't need to put any extra effort. So breathe in, make your belly go out, and then breathe out, belly go back. Now that's what we're recruiting the abdominal muscles. Do it a couple of times. Just bring awareness to your breath, to your mind. And then let's recruit the muscle above that, the diaphragmatic muscles, just around the lower rib cage. Breathe in through your through the diaphragm. Great. So now we got the awareness of the different parts of the breathing. Let's dive into the alternate nostril breathing. So it's very simple. So the right hand, the index finger goes on your right nostril. The other two fingers rest on your forehead. And then the ring finger controls your, the other nostril, the left nostril. So in fact, the thumb controls your right nostril. So let's do it again. The thumb controls your right nostril. These two fingers goes there, and the ring finger goes on your left nostril. So breathe in, and then breathe out. Close your right nostril and breathe in through your left nostril. And then close the left nostril with your ring finger and breathe out through your right nostril. Breathe in through your right nostril. Close the right nostril with your thumb and breathe out through your left nostril. Breathe in through your left nostril. Close the left nostril. Breathe out through your right nostril. That's one cycle. If you can do 5 minutes of that, it will calm you down and you can go into a deeper meditation or just do the breathing exercise by itself. Thank you for coming, Neha. Thank you for doing the breathing exercises with us. We'll put your phone number and your office address. You have an office in Palm Harbor, correct?
Correct. I have an office in Palm Harbor and Largo, and I may be also opening a new office in the Bayfront area as well.
Oh, okay. So
St.
you
Pete.
already have an office in Palm Harbor and Largo and maybe in St. Pete. Okay, great. So
Correct.
we'll put your phone number, and anyone needs a good oncologist, and well qualified, Dr. Makani will do a good job. And
Thank
then
you.
with that, we come to the end of our uh, webcast, and we're going to have a special Christmas one for the next go round. So do tune in. We got Debbie is putting together a Christmas show for you guys from our office. So we're not going to bring any special guests, but it's going to be a lot of special guests from our office. So with that, we come to the end of the podcast. Be nice to yourself. Look in the mirror and smile. Be nice to your fellow human being. Be nice to the friends and family, your neighbors, and be nice to the biosphere. Namaste. At Mahajan Medical Center, we care to listen to our patients. Proudly serving the needs of Tampa Bay in primary care for 25 years and counting.